Hello, my name is Riley O, and today I'm excited to present my project, a scoping review of AI in the loop for decision-making in lung cancer screening. Lung cancer remains the leading cause of cancer-related death worldwide. Every year, it claims millions of lives, often because it's detected too late. Screening gives people a chance at an earlier diagnosis, while treatment can still make a difference. Radiologists use chest X-rays and CT scans to detect tiny lung nodules before they become invasive. But as screening programs expand, radiologists need to review thousands of images each day. The workload can lead to fatigue, delays, and even missed cancers, all of which limit the benefit of screening. To meet this challenge, researchers have turned to computer-assisted detection systems, particularly artificial intelligence, or AI, which can flag suspicious findings based on patterns learned from massive imaging datasets like the National Lung Cancer Screening Trial. However, many studies test AI alone, not in real-world settings where humans and AI work together, what we call AI in the loop. So this gap raises some pretty important questions. How does AI actually compare to human readers in practice? And what is the most effective way to integrate AI into a radiologist's workflow so that patients genuinely benefit? Our objective is to find out and understand how human and AI collaboration can enhance real-world decision-making in lung cancer screening. So we'll accomplish this by synthesizing recent literature evaluating AI tools in lung cancer screening, focusing both on diagnostic performance and on workflow integration. We performed a scoping review following PRISMA screening guidelines. We screened MEDLINE Ovid, Embase, and Scopus for studies published from 2020 to 2025, evaluating lung cancer screening and AI and lung cancer screening, using CT or chest X-ray imaging. To be included, studies had to report real clinical data, report diagnostic performance metrics, and compare AI to radiologists directly. I led the database search and study summaries, charted data, and developed the final workflow categorization. So what did we find? Across studies, 4 main workflow models emerged. In the concurrent setup, the AI and the radiologist interpret images together in real time. In the first reader model, AI triages likely negative scans before the human review. In the second reader model, AI double checks the radiologist's interpretation. Standalone means that AI just reads scans independently, and results from the radiologist-only groups were just used to compare human performance. All studies are retrospective, and as we can see here, they use pretty diverse algorithms and diverse data sets. Therefore, even based on the diversity of performance metrics, it's just hard to compare between studies. However, out of studies that did evaluate sensitivity and specificity, which are our 2 main metrics, we can see that sensitivity and specificity varied widely. Here, each shape represents a different detection type, and colors correspond to workflow roles. We can see there's no single best cluster. Purple here is the radiologist cluster. You can see Standalone sometimes does better, sometimes does worse, but it's kind of all over. You can see the concurrent ones kind of perform similar to radiologists. Second reader and first reader show some promise, but they're kind of also all over the place as well. So this visual really illustrates the broader pattern of heterogeneity. There's diverse algorithms, diverse data sets, diverse metrics, which really make it hard to directly compare outcomes. But the pattern is pretty clear. AI works best not as a replacement, but as a collaborative partner, which helps humans catch more cancers while relying on clinical judgment to minimize overdiagnoses. These patterns show where human-AI collaboration can add value, which improves sensitivity but risks overdiagnosis, which directly informs our research question. Finally, our next step is to model these workflow configurations using OncoSim-Lung, a Canadian microsimulation platform, to estimate how AI-assisted screening could affect early detection rates, radiologist workload, and overall efficiency as provincial and national screening programs expand. Ultimately, our goal is to inform how AI can be integrated safely and effectively into provincial and national screening programs, strengthening rather than replacing human expertise at the heart of care. I'd just like to briefly acknowledge Drs. Darren Brenner and Matt Workington, who are my supervisors, Dr. Alain Tremblay for his guidance, the Candor Research Group, and the Diane Laflamme Macaulay Summer Undergraduate Research Award for this opportunity. Thank you.